Thank you. It's great to be here today and talking about these stress presentations. I'm going to explain what I mean about that in adolescents in English schools. Okay. So, as you've heard a lot today, mental health in schools is a government priority, and that's unlikely to change given the high frequency and burden of these mental health disorders, and of course their significant and lasting impact on learning and education outcomes. And of course, in addition, there's the promise that early intervention offers opportunities for improving long-term outcomes and ultimately for reducing pressures on secondary care services. So the question that this talk is going to think about is how and do schools influence adolescent mental health? And I'm going to talk a little bit about some of the strengths and limitations of administrative data for trying to disentangle this difficult question. So in this talk, we're thinking about schools as both a potential source of stress, but also as a potential source of support and the roles that they may play in the identification and treatment seeking behaviours as well. So a little bit about measures of stress and distress and administrative data sources and how we can measure them. So the data that I'm going to be talking about today is ECHILD. It's come up a little bit today so far, but I think this is the only talk which uses ECHILD to show results from it. So ECHILD is administrative data. By administrative, I mean it's routinely generated through interactions with healthcare, specifically hospitals, children's social care services, and also through schools. So in a nutshell, what this data ECHILD actually is the bringing together of hospital episode statistics data, so routine hospital data, and education data and social care data for all children and young people in England. So in total, that's about 14 million pupils. So this data is longitudinal. It covers records for children from birth up to the age of 24, and that gives the scope to understand their life histories up to that point through their interactions with health, school and social care environments. So one of the great strengths of this kind of data is the broad coverage. So this is whole nation in the case of England, where we expect that almost all children who come into contact with these services will be included in these data sets in some way or other. And as you heard from Becca earlier, it's also a strength that it is subject to less selection biases because it's not an opt-in process to be included in this data set. One of the things that we've done as part of the development of eChild is a lot of patient and public involvement. And this has included lots of discussions with young people and their families. And what they've told us is that mental health, and particularly mental health in relation to schools, is really important to them. And that's really driving forward some of our use of this data and our interest and commitment to trying to understand children's mental health with it. So if I can have the next slide. So one of the challenges, however, of working with this kind of data, particularly in the mental health context, is that there's a huge amount that is missed. So if we think about hospitalisations and deaths, which are included in the eChild database, what you can see from this clinical iceberg is that there's an awful lot that is missed. So in the case of self-harm, for example, which is one of the subsets of the presentations I'm going to be talking about today, we would expect from community surveys to see that something like 10 to 25% of children and adolescents will report ever self-harming. But if you look at data from hospitalisations, then this is more like 4%, so 1 in 25. And this reflects both the most severe cases, and it's also biased towards certain types of presentations, particularly self-poisoning and overdose relative to cussing, for example. However, these presentations are still really important, and they reflect actually a really significant healthcare burden and a huge personal burden as well. Next slide. So in this study, we're looking at stress-related presentations. So even what we call this is really difficult, and there's a great deal of disagreement across the literature, and there's absolutely not one definitive definition which is used. So in our study, or in some of the studies I'm showing you data from today, we've considered stress presentations as emergency hospital admissions, where the main reason for that admission, so that's the primary diagnosis, was a stress-related code. And we define these stress-related codes both from literature review and also through discussion with clinicians. And the other subset of codes that we looked at was self-harm presentations, but this didn't have to rely on the self-harm being recorded as the main reason. If you can go forwards, thank you. So just to give you a kind of flavour of what kinds of codes and the one way in which they can be grouped, I've shown you basically what the spectrum is. So we've got somatic and pain-related presentations. So these are kind of physical symptoms that don't have an identified medical basis. So typically this is unexplained abdominal pain, headaches, but also things like feeling breathless, fainting or fatigue when there's not been a medical cause identified. We've also got self-harm behaviours. This is typically cutting and poisoning. Mental health related, so particularly anxiety, depression and eating disorders, and other externalizing behaviours. So this is typically disruptive behaviour and substance misuse. Okay, so on to the results. So the key thing that is always quite shocking, I think, is that these types of stress presentations account for a really significant healthcare burden. So about 31% of all emergency hospital admissions in adolescents aged 11 to 17 years. Thinking about these individual people affected as well, this accounts for a really significant proportion of them. So 8% of all girls and 4% of all boys aged 11 to 17 were admitted to hospital at some point during that age with one of these stress presentations. And what the graph shows here is that these stress presentations were higher in girls, so they're shown in the two lines which are in black at the top, than in boys of the same age group, which are the two grey lines. And also that stress presentations were higher in weeks which occurred during school term times, so that's the solid lines, compared to the holiday periods, which are shown in dashed lines there. And that was particularly true for girls. What I would say here is that we don't understand the mechanism that's driving this. So is that school as a stressor, or is that actually schools as increasing uptake of healthcare services? Next slide. So there's a lot on this slide, but what you're looking at here is 3 academic years worth of data, so spanning from the last full academic year before the pandemic, which is 2018-19, 2019-20, which of course includes the first wave of the pandemic. And you can see just about the darker grey lines here, which show the times at which schools were closed, and the lighter grey lines correspond to school holiday periods. And then the year sort of after the first wave of the pandemic, so 2020-21. Girls are shown on the top row and boys are shown on the bottom row. And the key point to take from this slide is that during the first wave of the pandemic, so at the first lockdown, like virtually everything that was seen, or like virtually everything which can be measured in hospital admissions in children, there's a huge drop in presentations relating to stress. This doesn't relate to the need for this kind of treatment, but almost certainly to a change in healthcare seeking behaviours. So by the summer of 2020, rates were back up at pre-pandemic levels. And then if you compare the whole of the 2021 academic year to the 2018-19 pre-COVID year, then in girls, there's quite a significant increase in stress-related presentations, but we don't see the same for boys. There was no change. So then thinking about a single academic year, this is the last before the pandemic, 2018-19, and what we can see is that about 1.2% of all pupils had any stress-related presentation, and the majority of these relate to somatic and pain-related, followed by self-harm, and then a mixture of externalizing mental health-related, Just a reminder, the externalizing of primarily substance misuse and the mental health related, primarily anxiety, depression, and some eating disorders as well, or mixed types of these stress presentations. So this slide then shows children nested within the schools that they attended during 2018-19, which is why their overall percentage of pupils affected is just slightly different to the previous slide. So the take home here is that in an average size school of about 750 pupils across years 7 to 11, about 11 pupils per school were admitted with a stress-related presentation, and that this affects the vast majority of schools, so about 96% of them. Next slide. And then if we consider pupils who have a history of one of these stress presentations occurring in the years before 2018-19, but still within from ages 10 and over, then there are about 22 pupils per school who have a personal history of one of these stress presentations. So overall, almost all schools included at least one pupil with a stress-related presentation. However, actually what we're finding from multi-level modelling, which is ongoing, but you also see some results now, is that these school effects account for the individual school effects account for a relatively small proportion of the variance in these stress presentations. Next slide. And that instead, it's really pupil characteristics measured at the individual level which are most important. So this is a visual overview of that. And what we're seeing is that factors like having certainly a personal history of one of these stress presentations, but also chronic health conditions, having had contact with social care services, being in a white ethnic group, older school years, having free school meals and provision, and this history of it being ever excluded or having persistent absence in the prior year are particularly important factors. And the key point from this is that although these are individual level characteristics, they are actionable points for schools. Perfect. And then the next one. So to sum up, do schools influence adolescent mental health? Well, it's a very complicated story to try and unpick. But I think what some of the evidence that I've shown here, so these evidence of term time peaks and stress presentations, suggest yes, but that this may not be, well, the mechanism isn't clear. We also see limited evidence of these school effects on stress presentations, but I think school responses and whether they're supportive or punitive in their responses to pupil absence and exclusion are likely to influence these stress presentations. But caveated by saying these relationships are really complex and they require some really careful unpicking using both longitudinal methods, which we have used to a certain extent in this study, but also mixed methods as well. Thank you.